Good morning, one and all. A warm welcome to Swapna's Radio Info. In this talk, let me highlight the few important points regarding the uterine biophysical profile, which we are doing for all IVF cases in our routine practice. Uterine biophysical profile is a sonographic examination of the uterus that assess seven sonographic characteristics, which are used to predict the successful conception. Endometrial receptivity is defined as a temporary unique sequence of factors that make the endometrium receptive to embryonic implantation. So before going to further slides, I shall quickly brush through the arterial supply of the uterus. As you know, uterine artery is a branch of the internal iliac artery. It enters the uterus at the cervicocorporal junction. This is the point where we do the uterine artery Doppler. From here, it ascends along the lateral wall of the uterus, and at the cornua, it gives a ipsilateral branch to the ovary and gets anastomosis with the ovarian vessels. This uterine artery anastomosis with opposite side through the anterior and posterior arcuate vessels. So you can clearly see this arcuate artery, which is located at the outer and middle third of the myometrium. From the arcuate artery emanates the radial artery, which runs perpendicular to the through the myometrium, and it ends at the outer layer of the endometrium as a two terminal branches. One are straight is a basal artery, which supplies the basal layer of the endometrium. Other is a tortuous spiral artery, which we are very much interested. It supplies the functional layer of the endometrium, and these spiral arteries are responsive to hormonal changes of the menstrual cycle similar to the endometrium. Coming to normal endometrial changes in the menstrual cycle, if you see in the menstrual phase, it is seen as a thin echogenic line. In the early proliferative phase, you can see the subendometrial haziness. In this late proliferative phase, you can see the triple line pattern. In the secretory phase, you can see the uniform bright hyperechoic because of hyperplasia of the secretory glands. Coming to the endometrial assessment, transvaginal ultrasonography is often used to examine various parameters of endometrium like endometrial thickness, morphology, and blood flow status to predict the uterine receptivity. Endometrium pattern, endometrium thickness, and end-diastolic blood flow were shown to be most effective combination for the evaluation of the uterine receptivity. So coming to endometrial thickness is defined as the maximum distance between the echogenic interface of the myometrium and endometrium measured in the plane through central longitudinal axis of the uterus. You can see the two cursors measuring the endometrium here. This is the longitudinal axis of the uterus. Endometrial thickness in greatest AP dimension of 7 mm and greater is associated with the high pregnancy rate. Coming to endometrial pattern is relative echogenicity of endometrium and myometrium as seen as a longitudinal transvaginal scan. Smith et al. Classifies the endometrium into four types according to the echotexture pattern. Grade 1 is hyperechoic, grade 2 is isoechoic, grade 3 is triple line or trilaminar, grade 4 is echogenic black region surrounding the midline echo. So these are all the endometrial images you can see. This is a grade 1 hyperechoic endometrium. This is a grade 2 isoechoic to the myometrium. The grade 3 triple line or trilaminar pattern. This is very important. This is a grade 4 echogenic black region surrounding the midline echo, as in menstrual phase. There is another classification by Gonen and Casper in 1990. There are three types. Type 1 is entirely homogeneous. Type 2 is intermediate isoechoic pattern. Type 3 is multi-layered or triple line pattern. Coming to the uterine blood flow, Doppler of uterine arteries is very important. A good blood supply towards the endometrium is an essential requirement for implantation. Uterine blood flow is measured by color Doppler of uterine artery at the cervicocorporal junction. The impedance of blood flow through uterine arteries may be expressed as two indices. One is pulsatility index, other is resistance index. Assessment of myometrial blood flow and endometrial blood flow should be done better with power Doppler. The flow of blood in endometrium is of low velocity. If one sweeps through the endometrium too quickly, hastily, flow may not be seen. Endometrial blood flow has a mercurial personality. It may appear as if it comes and goes. In the uterine arteries, the pulsatility index was highest on the day 2, after which it decreased successfully to its lowest value, whereas the time average maximum velocity reaches highest value on day 1. Perfusion of endometrial cavity increases in response to circulating estrogen and progesterone and decreases with the periovulatory fall in estrogen. Lowest PA seen around day 21, which is the time of implantation. So these are the transvaginal color Doppler ultrasound of both uterine arteries in a fertile woman. You can see the mean PA is 1.5. This is a very favorable for IVF. This is a transvaginal color Doppler ultrasound of uterine arteries in infertile women. You can see very high resistance flow. Here the mean PA is 2.5, which is unfavorable. The uterine blood flow impedance was significantly higher in women that were diagnosed with unexplained infertility more than fertile women. High uterine impedance and low endometrial perfusion diagnosed by uterine artery Doppler may contribute in etiology of unexplained infertility. Now coming to the division of endometrium and periendometrial areas based on the vascularity. We have the 4 zones. Zone 1 is 2 mm thick area surrounded by hyperechoic outer layer of endometrium. Zone 2 is a hyperechoic outer layer of endometrium. Zone 3 is hypoechoic inner layer of endometrium. Zone 4 is endometrial cavity. So in this image, you can see very clearly, this is zone 1, this green line is zone 2. Inside the green line here, this is the zone 3 and central hyperechoic is zone 4. These are the transvaginal color and power Doppler images. You can see this red within the zone 1 here. It's touching the hyperechoic layer. This is the zone 2. It is inside the hyperechoic layer. This is the zone 3. It's touching the midline echo. This is zone 4. Now you can see this is a transvaginal color Doppler ultrasound. You can see the entire uterus, fundus, body, and cervix. This is a cervicocorporal junction where you can see the uterine artery by means of color Doppler. Just put on the spectrum. You can see the very good flow in the uterine artery. By autotrace method, you can measure the indices, both S by D, PI, and RI. So in this image, you can see the vascularity within the myometrium inside the arcuate vessels. So this is very good. And you can see the triple line endometrium here, and you can see the sparse blood flow in the zone 3. These are the 3D reconstructed images both in the sagittal, axial, and coronal plane of the uterus, showing the sparse blood flow in the zone 3. This is a similar image. Coming to the sonographic qualities of the uterus during the normal mid-cycle. Endometrial thickness in the greatest AP dimension of 7 mm of greater full thickness measurement. A layered 5-line appearance to the endometrium. Blood flow within the zone 3 using the color Doppler technique. Myometrial contractions causing a wave-like motion of the endometrium. And uterine artery blood flow as measured by PI less than 3. Homogeneous myometrial echogenicity. Myometrial blood flow seen on grayscale examination internal to the arcuate vessels. So these 7 parameters are very important. Coming to uterine biophysical profile, we have the uterine scoring system for reproduction comprising the following parameters taken in the mid-cycle. So we have the endometrial thickness first. If it is less than 7 mm, we shall give 0 points. If it is 7 to 9, 2 points. 10 to 14 mm, 3 points. More than 14 is 1 point. Next is endometrial layering. If there is no layering, you give 0 points. If it is hazy trilaminar, give 1 point. With distinct trilaminar, give 2 points. Myometrial contractions, if less than 3 contractions in 2 minutes, give 0 points. More than 3 contractions in 2 minutes, 1 point. Myometrial echogenicity, if it scores heterogeneous, then we give 1 point. If it is homogeneous, we give 2 points. Next is uterine artery Doppler, PI. If it is greater than 3, 0 points. PI 2.5 to 2.99 is 1 point. PI 2.2 to 2.49 is 2 points. PI less than 2.19 is 3 points. Endometrial blood flow in zone 3, that is a hypoechoic inner layer of the endometrium. If it is absent, so give 0 points. If it is sparse, give 2 points. If it is abundant, give 5 points. Myometrial blood flow internal to arcuate vessels. If it is absent, give 0 points. If it is present, give 2 points. By adding all above observations, we need to give endometrial receptivity score. So this is the chart which we are following in our setup. We shall give all the points. At the final, we'll give the total score by adding all of the above. So coming to the percentage of conception rates by USSR score, the score of 20 and above, the conception rate is highest 100%. With the scores of 17 to 19, the conception rate falls to 80%. With the scores of 14 to 60, it falls to 60%. If the score is 13 and less, the chance of pregnancy is highly reduced. Endometrial, if it is a blood flow is absent, there is no chance of pregnancy. Coming to conclusion, transvaginal color, power Doppler, and 3D power Doppler evaluation of the endometrium and subendometrial blood flow is a very simple, non-invasive, and effective method to evaluate endometrial receptivity. High degree of endometrial perfusion shown by color or power Doppler indicates a more receptive endometrium. Uterine scoring will help to perform embryo transfers in only favorable uterine score and cancel or postpone those cycles in which poor uterine score is demonstrated. So these are the very important references which we have taken. These are the various references. I would like to thank my consultant, Dr. Anita. Thank you so much.